Okay, so tonight we'll be talking about cardiac emergencies, which there's a lot of go hand in hand with this lesson. Um, you do know that cardiac related illnesses are the #1 killer of adults in the United States. Still remains to be that even up today. There are different types of emergencies related to the cardiovascular system. Some of them are readily treated by the EMT, some are more delegated to the paramedic. Um, but the treatment and management of cardiac related emergencies at the BLS level is growing and growing. So it's pretty important to have a good understanding of A, the anatomy and physiology of the cardiovascular system, B, the pathophysiology involved in the cardiovascular system, and then the specific emergencies and treatments related to the cardiovascular system. So again, we talk about the cardiovascular system itself and talk about the anatomy and the physiology. What is the purpose of the cardiovascular system? It's to transport oxygen and nutrients to each and every cell in the body, and just as importantly, remove and transport waste material from each and every cell for elimination in the body. And it does so every minute, every hour, every day of your life. We know that that process is called perfusion. And it's very important to maintain an adequate perfusion because that's the first sign of a person dying is lack of perfusion. And so what are the three main components of the cardiovascular system? You have the blood vessels, and the heart. The blood is the transport medium that carries the oxygen and the nutrients throughout the body. The blood vessels are the pipelines, the container, and the heart is the actual physical pump. Now, the blood itself has four main components. There are the erythrocytes, or the red blood cells, which actually carry the oxygen molecules because oxygen cannot really diffuse through the liquid part of the blood very easily on its own. There's the white blood cells, or it's medically called leukocytes, and their job is to engulf bacteria and pathogens and initiate an inflammatory response as well. There's the platelets, which are responsible for clotting the blood, which can be a good thing or a bad thing. If you cut your face shaving, you want the blood to clot. You don't want the blood to clot and the blood vessel going to the brain. And then there's the plasma, the liquid portion of the blood, which is mostly water, but also contains some proteins and electrolytes as well. And you can see from this diagram, the circulatory system is really a dual system. It has two different sides. It has a systemic component and it has a pulmonary component. You might say that the left side of the heart is involved with the systemic component, which is involved in delivering blood to the body, mostly oxygenated blood. And the right side of the heart, now remember, we're looking at the patient's right side of the heart, is the pulmonary circulation, which is involved in transporting blood to the lungs to pick up oxygen and bring it back to the left side of the heart. So if you can imagine it almost as a sideways figure 8, it goes round and round continuously. It's very important that you know the major anatomical structures of the heart. The heart is a hollow muscular organ that sits in the middle of the center of the chest in a space called the mediastinum. It has three major layers. It has an outer fibrous layer called the epicardium. It has a thick muscular layer called the myocardium. And then the inner lining, which is smooth and kind of sticky free like a Teflon lining, is called the endocardium. It has four hollow components to it, two upper, two lower. Two upper components are called the atria. Two lower components are called the ventricles. The atria are the receiving chambers. The ventricles are the shipping chambers. The right atrium receives deoxygenated blood from the rest of the body. From the right atrium, blood flows into the right ventricle. About 60% or so of that blood flow is passive. It just pours right from the atria to the ventricle without any activity. The other 30 to 40% of that blood is pumped actively when the atria contracts and then fills the ventricle. As the ventricle swells up and becomes filled with blood, before it contracts, it closes down a valve that prevents blood from going from the ventricle back up into the atria. That is called the tricuspid valve. Tricuspid valve. So blood goes from the right atria to the right ventricle and is prevented from flowing backwards through the tricuspid valve. So you got all this deoxygenated blood in the right ventricle ready to get transported to the lungs. So that ventricle is going to contract and it's going to shoot blood through this main artery called the pulmonary artery. If you want to get really specific, the first branch of the pulmonary, or the first part of the pulmonary artery, is called the pulmonary trunk, like the trunk of a tree. And then it splits into the left and right proper pulmonary arteries. But if you just say pulmonary artery, that's fine for me. Now remember, arteries stretch out and spring back. They're very muscular, they're very forceful. So what's going to prevent blood from spurting back into the ventricle? This structure here called the pulmonic semilunar valve, or pulmonary valve. So the ventricle contracts, pushes blood into the pulmonary artery. That artery is going to expand, stretch out, and then it's going to contract to try to propagate that blood back to the lungs. It's going to be prevented from flowing back into the ventricle when this semilunar valve shuts down. So the blood can only go one way. Then the blood, you can't see it on this diagram, but the deoxygenated blood is going to go to the lungs, pick up oxygen through the capillaries, and it's going to bring the oxygenated blood back to the left atrium. And same as before, about 60% of that blood flow from the left atrium to the left ventricle is passive. It just pours right in. The other 30 to 40% occurs when that atria contracts and squeezes blood into that ventricle. And that left ventricle is really the workhorse of the heart. And you can see by its thicker muscle mass in this diagram as compared to the right ventricle. So as that ventricle fills up with blood, it's going to begin contraction, and it's going to cause this valve over here, called the mitral or bicuspid valve, to close off, to prevent blood flow from going from the ventricle to the atrium. So now when that mitral valve closes, the ventricle contracts and it pushes blood through the major pipeline of the body called the aorta, all this brand new oxygenated blood. And then from there, that aorta is going to split off. It's going to split off into different arteries and arterioles, and capillaries. And if all goes well, it's going to distribute blood to the rest of the body. That's if all goes well. What if all doesn't go well? If all doesn't go well, then we got a situation called an acute coronary syndrome. Acute coronary syndrome is really sort of a catch-all phrase for a few things that can happen when the heart itself is compromised and it's not getting its own supply of oxygenated blood. So if you get to that call and it comes in as a cardiac, you come on the scene, you do your scene size up. It's a typical peaceful looking neighborhood home, no obvious danger, calls medical, no reason to think that you need any additional resources right now. So let's skip all that. Let's go into our general impression. What do you see here on this general impression? Well, you see a little older middle-aged male in obvious distress. You don't know what's going on, but it's hard to tell from a two-dimensional photo, but doesn't look like there's any need for C-spine immobilization. Doesn't look like there's any immediate life threats, like his head's getting chopped off, but he does look very uncomfortable. So how would you proceed? Hello, my name is Steve. I'm an EMT. How may I help you today? My chest is killing me. Okay, so what do you know about his mental status? It's alert. What do you know about his airway? It's open. Is he breathing? Just by looking at the picture, you could probably tell he's breathing. Is he breathing adequately? Probably. Would it hurt to give him oxygen at this point? Probably not. Especially if he says, my chest hurts and I'm having trouble breathing. What's his circulation? How would you evaluate his circulation in the primary assessment? Would you stick your fingers in his carotid artery? Okay. All right. That might be met with some resistance. How would you check this patient's circulation? Radial pulse is a good start, John. How else? What else are you looking for? What about his skin condition? Okay. Well, if he's pale and sweaty, is that also a concerning sign? Sure. It might be a sign he's going into shock, but it also could be a sign of other things as well. If he's got a radial pulse and he's cool, pale, diaphoretic, something serious is going on. So is this guy high priority or low priority? High priority. So what do we want to do? We want to reevaluate this patient. If we didn't have ALS on the way now, is now a good time to call for them? All right, good. So we want to give a brief presentation, tell the ALS what we got. I got a 57-year-old male complaining of chest pain. He's alert. He's awake, alert. Obvious distress, more information to follow. Focused history and physical. Focused history. So what are some questions you want to ask this guy? Well, he's having chest pain. So let's focus on that chest pain. What were you doing when this pain began? Was he working? Was he sitting? Was he sleeping? Did it wake him up out of his sleep? Does anything provoke this pain? Does anything make it worse? Like if he stands up or exerts himself or takes a deep breath. Oh, with that question, does anything make it better? Like if he sits down at rest, or if he takes a deep breath, or if he takes any of his pre-prescribed medications. Does the pain radiate anywhere? Does he feel it anywhere else, like his shoulder, his jaw, his back? Now, again, are you going to ask a patient in those exact words, sir, does your pain radiate anywhere? What the hell are you talking about? Try to reword your questioning in terms that most patients are going to understand. Are you feeling this pain anywhere else? And don't try to put the words in their mouth, but just try to get it out of them. How severe is this pain on a scale of 1 to 10? It's an 11. Well, obviously you failed math class as a kid, but on a scale of 1 to 10 right now. Now, if he tells you it's an 8 out of 10 at this moment, does that give you any idea how bad his pain really is? No, it doesn't, because pain is subjective. However, if he's telling you it's an 8 out of 10 now, and you've helped him with some nitroglycerin, you give him some oxygen, you laid him down, and he's telling you in 10 minutes it's a 5 out of 10, is that important information? Say yes. Everybody say yes. And then finally, time. How long has this been going on? Is it 20 minutes? 20 days? You'd be surprised. Sometimes people say they've been having chest pain on and off all week, but with that, then why did they call tonight? Something different? Did something change? Or did they just not get around to it? I'd be surprised. So after you get that focused history, you want to do a focused physical based on the chief complaint. So you want to think about head to toe, what are the obvious signs of cardiac issues? We'll go back to that in a few minutes, okay? Obviously, excuse me. Well, we'll talk about that in a few minutes. Some diagnostic tests we can do. Any idea what's one? What are some tools that we can use besides our blood pressure cuff and our vital signs? What are some other diagnostic tests or diagnostic equipment that we have to see how this patient is doing? Very good, Jazeera. Yes. In some instances, in most places now, BLS are authorized to apply, obtain, and transmit what's called a 12-lead EKG. I may have to come back at some point and go over EKGs with you. I don't have it on this lesson because it's relatively new. Now, it's beyond the scope of the EMT to read and interpret EKGs, even though you might have some training in it previously, but it can make a world of difference as to where this patient gets transported. So absolutely. Um, Anything else any other tools we have to see how this patient is doing? Going back to your ABCs. Well, we're obviously thinking this person's the thing they breathe into. Talk about a spirometer. Generally, that's not gonna. That's a good. Some ambulances actually carry that for severe respiratory problems, but this person's having a cardiac problem. And I'm sorry I didn't see the name, but somebody said check oxygen level with what? Get a blood sample. How do you check his oxygen level? Pulse oximeter, very good. Yeah, so you have some tools available to you to help you out. Pulse oximeter and EKG. So we'll get back to that. So right now we got to think about what's going on. This person may be having something called an acute coronary syndrome, what we would commonly refer to as a heart attack. Now, what's going on with most heart attacks? At some point, the heart is not getting enough oxygenated blood. And what's causing that? Well, think about it. We just talked about how oxygen and blood goes through all 4 chambers of the heart every minute of every day of your life. However, that blood that goes through the chambers of the heart does not feed the heart muscle itself. The heart muscle has to get its blood supply from a different mechanism. And it gets its blood supply from these blood vessels that wrap around the heart. They're the first arteries that branch off the aorta, and they feed the oxygenated blood to the heart muscle itself. These arteries are called the coronary arteries. Now, these coronary arteries are the first arteries to get their fill of all the oxygen, nice new oxygenated blood that just came from the lungs and delivered to the heart. But they're also the first arteries to get their fill of all the crap we put into our body. The Taco Bell, the nicotine, the Easter eggs, the candies, jelly beans, right? All right, so these arteries are very, very subject to something called atherosclerosis or coronary artery disease. Atherosclerosis involves the buildup of fatty deposits on the inside of the artery, which does a couple of things. It narrows the diameter of the artery, making passage of blood more difficult. Now, a lot of people, most people, probably most of us in this classroom, have already some level of atherosclerosis in our arteries already. A little bit is actually tolerated pretty well. But over time, these fatty deposits can grow and grow and grow, further diminishing blood supply to the point where a person may start feeling it on exertion because they're having a harder time getting oxygenated blood to a heart that's working harder. But these fatty deposits also change the integrity of the vessel wall. It causes inflammatory changes and structural weakening of that wall. So it used to be thought that if you could just go in there and scrape out that plaque, you'd fix the whole problem. It doesn't work like that, though, because even though you scrape out the plaque, the damage to the artery has already been done. So that's a problem. Now, over time, like I said, one of 2 things can happen. Well, one of 3 things can happen. Either nothing can happen, the person can just die of old age and have a happy old life. That plaque can grow and grow and grow to the point where that blood vessel is about 70% blocked off, and then they start feeling all these symptoms, and then they make an appointment with their doctor, and the doctor sends them to a cardiologist. Cardiologist sends them for a bunch of tests, like a stress test and maybe an angiogram, and they decide that, oh, we got to do something about this. Or a person may feel nothing, and because of the damage to that artery, at some point in time, the inside, the lining of that artery gets a little tear from all that structural damage, and now it's exposed to the blood itself. And whenever blood comes into contact with damaged tissue, what does it like to do? What's it supposed to do? Give you a hint, a little indicator, fingers pointing right to it. No, blood doesn't swell. As the blood's flowing through the vessel and it comes up to a disruption or a tear in that blood vessel wall, it clots. It clots, and it's supposed to clot. The problem is, now as that clot gets bigger and bigger and bigger, it completely blocks off all blood flow in that artery. And as blood flow is blocked off, whatever part of that artery is feeding, whatever part of that heart is getting fed by that artery is not getting any oxygen. And so that person is in the process of having a myocardial infarction, or what we medically or colloquially call a heart attack. If that blood vessel, that artery continues to be blocked, that piece of the heart will ultimately die. Now, if it's a small piece of the heart, patient may make a complete recovery, or at least mostly a complete recovery. If it's a huge part of the heart, person may live with diminished capacity to function for the rest of his life. They may need oxygen. They may need to be in a wheelchair. If it's really bad, they may just go into sudden cardiac arrest. And nobody wants that. So this is what we refer to as a acute coronary syndrome. So the first thing to recognize about acute coronary syndromes are the typical signs and symptoms, most common of which would be chest pain. We saw that patient in the earlier slide clutching his chest. All right. Now, chest pain can be described in a number of different ways. It could be pain, it could be sharp, it could be dull, it could be tearing, it could be a pressure, elephant sitting on my chest, and a burning, an uncomfortable sensation. 5 different people could be having a heart attack at the same time and describe what they're feeling 5 different ways. So you have to have a real low threshold for suspecting what's going on. So as I say, the heavy sweating. All right, again, if somebody just ran up and down a flight of stairs, that's one thing. Of course they're going to sweat. But if you're in a 68-degree room and a person's perspiring and they haven't been exerting themselves, that's a sign of something going on. That's a fight or flight reaction. And you know, a doctor I work with is actually pretty smart. Told me something a couple of years ago. He says, you know, what's the medical term for sweating? It's called diaphoresis. And you can't fake diaphoresis. A person could fake having chest pain. They could fake having shortness of breath. But you can't fake sweating. So take that very seriously. Extreme anxiety, or something some people may refer to as an impending sense of doom. Please don't think I'm being over dramatic, that when you have a person who looks like they might be having a myocardial infarction, acute coronary syndrome / heart attack, and their risk factors, which we talked about in CPR, suggest that they may have an acute coronary syndrome, and they tell you, I feel like I'm going to die. Oh God, I'm going to die. Please take that seriously. Make sure you have the defibrillator in hand and the BVM ready. I'm not saying to put it on somebody that's awake and breathing, but be prepared, because people that are about to drop dead usually know what's coming. That's very, very cardiologists recognize that. Fainting is obviously, when you have fainting, you got to worry about cardiac arrest. A lot of times patients will think they chalk their symptoms up to indigestion, you know, burping, gas, a little agita. Believe it or not, burping and gas can be a sign of a certain type of heart attack. A certain part of the heart that rests right on top of the diaphragm can mimic feelings of indigestion. So don't blow that off either, especially if they're older, a little sedentary, maybe have a couple of risk factors for a heart attack. Some risk factors. There are risk factors that can be controlled, and there are risk factors that can't be controlled. Risk factors that can be controlled, such as obesity, such as tobacco smoking, which is the #1 preventable cause of heart disease. Risk factors such as hypertension, which may not be controlled, but it can be modified. sedentary lifestyle, poor cholesterol profile. Some risk factors can't be controlled. Family history. If any baseball fans out there, a baseball player back about 15, 20 years ago, Darryl Kyle, I think his name was, pitcher for the St. Louis Cardinals, 31 years old, found dead in his hotel room the morning of a game. On autopsy, he had all 4 major coronary arteries blocked up. He had a major, massive heart attack at 31 years old. Well, the tox screen came back negative. No drugs in his system. Had a very significant family history. So take this into account. Shortness of breath. Sometimes shortness of breath may be the only symptom without chest pain. More common in your elderly. There are 2 major patient populations who usually don't complain of chest pain when they're actually having a heart attack or myocardial infarction in process. One is the elderly, and the other are diabetics. I think Danny will talk to you about diabetes on Wednesday. These populations tend to not read the textbooks. So again, have a very elevated suspicion, high index of suspicion. So this is basically comes down to what I just said. Chest pain is the best known symptom. It can be described in a number of different ways. Sometimes it's just a matter of not feeling right in their chest. You want to ask them, does this pain travel anywhere? Oh, if I have a patient coming in, they're 60 years old, and they say, my shoulder's been hurting me for the last couple of days, don't remember pulling anything or lifting anything heavy, didn't fall. What's the first thing I'm doing in that office? I'm putting an EKG on. Because sometimes that's all they complain of. It's really weird. It's something called referred pain. And why does it happen? Well, because the sensory nerves from the arm and the sensory nerves from the heart meet up together in an area close to the neck called the brachial plexus. And these nerves are very, very close together, and they're intertwined. It's a very complex structure of the nervous system. And sometimes a signal from the heart jumps over and gets picked up by a nerve that's sensing the arm. So the brain misinterprets what's going in the heart as something in the arm. It has nothing to do with the arm. Same thing can happen with gallbladder pain. Somebody who's having a gallbladder attack will quite often feel pain in their right shoulder. It's just a matter of a mixed signal. So don't let that distract you. Somebody who's elderly, obese, smokes, because they've got the worst jaw pain in their life, you think you call the ambulance for a toothache? Don't be so quick to blow it off. Is it a toothache or is it referred pain from an MI? Okay, most of the times, chest pain is the most common symptom, but don't blow off the atypical presentations as well. Okay, what is dyspnea? Dyspnea is just another fancy word for saying shortness of breath, maybe the only thing in some patients. Okay, and then we talked about anxiety, feeling of doom, nausea, pain, discomfort in the upper abdomen, epigastric pain. So don't blow it off as just being agita. Sudden onset of sweating. I had a patient in the ER years ago. She was about 80-something-year-old woman, very spry, very healthy. It was in February. It was flu season, and the reason she came to the emergency room was because she thought she had come down with the flu. Because she said in the middle of the night, she just sweat. And she thought she had the flu. And that's why she came. No chest pain, no shortness of breath. Blood pressure was a little elevated. That's all. But no other reason to think she was having anything going on. But just by protocol, we did a EKG on her. The EKG had some abnormalities. It was not definitive. So the way you actually diagnose a true heart attack in medicine is by grabbing some blood, sending it to the lab, and looking for what's called cardiac enzymes. When the heart is being damaged because it's not getting enough oxygen, it breaks down and it spills enzymes into the blood. And that's what we look for when we're diagnosing a myocardial infarction. And lo and behold, those enzymes came back positive. She was having a myocardial infarction in progress, and her only complaint was a cold sweat. But you got to look at the risk factors. 80-something-year-old female, And the medical literature has been somewhat biased against females over the years. It's only recently that we're really kind of discovering that women don't necessarily present the same as men when it comes to presentation of acute coronary syndrome. And that most of those studies have really only studied men. Women may not feel chest pain as often as men do. Women may feel more back pain or more nausea or more just of a sense of impending doom. So as we're learning more and more, we're learning that not how much we know, but how much we don't know. So it's an ever expanding field. Okay, so what to do for this person? Well, obvious patient assessment, perform your primary assessment. Now, primary assessment, the patient you saw in that previous photo is done in 15 seconds. Hi, my name is Steve. I'm an EMT. How can I help you? I have the worst chest pain and difficulty breathing. Boom. Your general impression is done. Your mental status is taken care of. Your airway, you know the airway is patent. You know they're breathing adequately, although maybe having some difficulty breathing, but you know you're not going to be slapping a PVM on them right now. You know they have a pulse because they're awake and talking to you. Maybe at that point, just feel the radial pulse, put your hand on their forehead, with their permission, of course, and feel their skin, color, temperature, moisture. And then make a priority decision. Reevaluate what's going on, call for ALS, get the history of physical, OPQRST, and sample, get those baseline vitals. If authorized to do so, in most places, I know New York City you're authorized, Nassau County you're authorized, grab that 12-lead EKG. What's so important about a 12-lead EKG? Well, what's the ultimate goal of treating this patient? When that blood clot forms, the clock starts ticking. So when that piece of artery rips and that blood clot forms, happens very quickly. But the show's not over. The heart can survive for some time. It goes through a process. It goes through ischemia, injury, and then finally infarction. It takes about 6 to 12 hours of oxygen deprivation for that part of the heart to fully die off. So if that circulation can be reestablished, or what we call reperfused, if we can open up that blood vessel, no, not we as EMTs, but we in medicine, before that 6 to 12 hour time frame, we can save that person's heart muscle. Maybe not all of it, but some of it. The sooner we can reestablish blood flow, the more muscle will be saved. The more muscle that is saved, the better prognosis, the better life that this person's going to have after that event. Now, I think you have a video on your lesson folder about percutaneous angiography, where they go in with a fiber optic wire under a fluoroscope or X-ray, so to speak, and they find that artery. They poke the fiber through the clot, and they open it up with a balloon. And then they reinforce it with a metal scaffolding called a stent. And that's usually the most successful way of reestablishing blood flow when somebody's having somebody's having a myocardial infarction. Not every hospital has that capability. So if you're familiar with Queens, for example, maybe you're working somewhere around Woodside, Elmhurst area, you're about, let's say, 6 minutes away from Mount Sinai, Queens in Astoria, and you're 10 minutes away from Elmhurst Hospital on Broadway. Now, by convention in EMS at the BLS level, we would obviously take this person to the nearest hospital, which would be Mount Sinai, Queens, 6 minutes away. Mount Sinai, Queens does not have the capabilities to do angiography and stenting. Elmhurst does. So if this person were to be taken to Mount Sinai, Queens, they would most likely have to be transferred from that ER to a hospital with a cardiac catheterization center. Well, why not just cut out the middleman? So now, not all chest pains are eligible for this treatment. So by putting 12-lead EKG on and sending it to medical control can make the determination that this person does meet criteria for cardiac catheterization and can authorize you to transport to the further hospital that has the appropriate resources. There are some municipalities, I don't think New York City is one of them, where the 911 ambulance will even go right and bypass the ER and go right to the cardiac cath suite if they call a cath code. But lo and behold, that's besides the point. By applying the 12-lead EKG, that can make a big difference in that patient obtaining the appropriate resources. And getting your patient to the appropriate resources is all about patient advocacy, right? Doing the right thing by your patient. So it's beyond the scope of this class to actually teach you how to apply and transmit EKGs. That's agency dependent. If we have time later on, though, I'll put together a little presentation about 12 leads, just to give you an idea, a little bit of a better idea about them. So what are you doing? Hey, Dan. Hey, Dan. You want to say hello? Guess not. Okay, so what do we have here? So we have a patient who's looks elderly, looks like someone in distress. Remember our communication skills. The EMT is not standing over him like an authority figure. You know, wife's probably offering some information, maybe too much information, but you want to get most of your information for the patient themselves if possible. Now here's another thing that we're going to talk about that kind of breaks convention. If a patient's having chest pain and chest pain alone, doesn't necessarily always mean they need oxygen. If they're not complaining of any shortness of breath and the O2 saturation is over 94%, oxygen may not be the best thing for them. And that's very hard pill for us old-time EMTs and medics to swallow. Because we were always told in the old days, everybody gets oxygen, everybody gets oxygen. You can do no harm with oxygen. It's not necessarily true. What does oxygen do to metal? It rusts it, it corrodes it. Well, oxygen is an unstable molecule. Too much oxygen in your system is a bad thing. It can cause structural damage at the cellular level. So if they're hypoxic, if there's evidence that they have low levels of oxygen, of course, give oxygen. But if they're not short of breath, if their O2 sat is in a good range, maybe withhold the oxygen, or maybe just give them nasal cannula at 2 liters per minute, just for a little comfort. Don't go necessarily blasting on oxygen in their face if they don't need it. Okay, so we just talked about that. Another intervention for this patient is a medication that Dan might have spoken about when we talked about pharmacology, is nitroglycerin. And nitroglycerin is a medication you can only give if it's already been prescribed to that patient. Not something we carry at the BLS level in the ambulance ourselves. And of course, when you're any time you're assisting with somebody's prescribed medication, you want to make sure it is their medication. And what is nitroglycerin indicated for? It's indicated for chest pain, presumably due to myocardial infarction or something called angina, or we'll just say deep coronary syndrome. And its goal is to relieve or help relieve chest pain. And it does so by dilating the blood vessels in the body. It's going to open up the coronary arteries. It may open up the coronary artery that's partially blocked. It's going to open up the veins as well, so it's going to reduce workload of the heart. It's going to allow the blood vessels to deliver more oxygen to the heart, and it may significantly reduce chest pain. It may not, in which case something else may be going on. It's usually administered either as a little tablet that goes under the tongue, in other words, sublingually. If they chew it up and swallow it, it's useless, because it'll break down the digestive system. So it's got to be absorbed under the tongue. Sometimes it comes in a little spray. The spray itself, again, has to go under the tongue, not on the tongue, like a little breath mint spray. Know the side effects involved with nitroglycerin, because patients go into feel some side effects. They're probably going to feel quite a bit of a headache, because not only does it dilate the coronary arteries, it dilates the arteries in the head as well. So they're going to feel like a migraine type headache. They may feel a little dizzy, a little lightheaded. Their blood pressure is going to drop. So you must get a baseline blood pressure, baseline all vital signs, prior to assisting with their nitroglycerin. Now, New York State and most other municipalities, assisting with a pre-prescribed nitroglycerin is standing orders. So you don't need to call medical control to get permission to administer, as long as you're doing it appropriately. And does anybody know what your blood pressure must be, systolic blood pressure must be in New York State in order to assist with somebody's pre-prescribed nitroglycerin in New York State? Because it's a little bit different than what your textbook says. Very good. If I get it over one, okay, good. I guess Danny must have hit that home. And of course, you want to make sure they're not taking any type of erectile dysfunction medications prior to administering nitroglycerin. You have to ask. Don't be shy. Don't be bashful. Don't be embarrassed, because it's important information to have. And then, of course, after you administer the nitroglycerin, anticipate the side effects, reassess the vitals, and reassess your patient's pain scale. Aspirin is another extremely important intervention. What does aspirin do? And don't say it's a blood thinner. Does not thin your blood, does not reduce the viscosity or the thickness of your blood. Aspirin makes the blood clot less. Exactly. It's a platelet inhibitor. It prevents one platelet from signaling to another platelet to come join the crowd and make a big clot, which is a good thing. It's a very powerful medication that's extremely indicated. What's the contraindication to aspirin? Well, allergy to aspirin, obviously. Any type of active GI bleeding, so they have a bleeding ulcer, you're not going to give them aspirin. Your textbook says asthma is an allergy, asthma is a contraindication to aspirin. It's really not. And New York State protocols will usually say aspirin is not a contraindication. They kind of argue with most textbooks. The national guidelines still listed as contraindication, but I would never test you on that, because it's just not true. You know, plenty of people with asthma who have been given aspirin with no issues. So, causes of cardiac conditions. Okay, heart problem caused by a number of disorders affecting condition and function of blood vessels of the heart. All right, so we know about coronary artery disease. There's two types of coronary artery disease. There's atherosclerosis and arteriosclerosis. Atherosclerosis is the buildup of fatty deposits on the walls of the arteries, where arteriosclerosis is the thickening and the hardening of artery. Remember, an artery has to be flexible. It's got to stretch out and spring back to work right. And this all occurs because usually of a blood clot that forms within the heart itself. Now, a blood clot can either build up in the artery and stay there, or it can break off and travel down the line and cause another problem. So, for example, not all chest pains are cardiac. A blood clot can form in the lower extremities, in the legs, something called a deep venous thrombosis. And it can break off and it can travel and lodge in the lungs. Does anybody know what that condition is called? When a blood clot travels into the lungs, it's called, almost to zero. Pulmonary edema is fluid in the lungs. When a blood clot breaks off and travels to the lungs, it is called a pulmonary embolism. Very good, a pulmonary embolism. That's something that we have to be very, very wary of when somebody's having chest pain and has risk factors. And they don't necessarily have risk factors for heart attack. You have a 30-year-old, otherwise healthy person having this chest pain and they're tachycardic. And sometimes they come off as a little anxious and histrionic, and you think, okay, this person's just having an anxiety attack. But what are the major risk factors for a, a blood clot forming and traveling to the lungs? Well, prolonged immobility is one. Somebody who's had recent surgery or who's been on a long travel, like a road trip from Florida to New York. Or, back in the days, you would have an appendectomy, you'd be in bed for 2 weeks recuperating. You get through the surgery fine, then you'd be discharged from the hospital and you drop dead down the block because you formed all these blood clots. These days, when you have surgery, what happens? They have you up and moving the day after, if not the day of, to help keep that circulation moving, to help prevent blood clots from flowing. Trauma to the lower extremities. Blunt trauma to the back of the legs can cause blood clots, which can travel to the back, up to the lungs and lodge in there. Anybody remember Muhammad Ali? Or at least know of Muhammad Ali? Please tell me somebody knows Muhammad Ali, please.
Yeah.
Okay, good. Thank you, Dan. Okay, good.
From Louisville, Kentucky. There's a big statue of him there.
Oh yeah.
Mm-hmm.
And it's like a real kick in the ass. In Philadelphia, they have that statue of Rocky Balboa, but never any thought to Joe Frazier, who represented Philadelphia. But anyway, getting back to Muhammad Ali, back towards like middle to the end of his career, he did this exhibition match in Japan with a professional wrestler, Antonio Inoki. It's the old, boxer versus wrestler, who's better. And as we were getting closer to the match, Ali's camp was getting a little more worried about how he would look in the ring. So they made all these rules where the wrestler was really limited what he could do against the boxer. So when the ring bell started and the match started, Antonio Inoki, what he did, the smart thing, he dropped down to the floor and just kept kicking and wailing away on Muhammad Ali's legs. And just kept kicking him. And Muhammad Ali, he's a boxer, so he couldn't use his range, he couldn't use his jab, his cross, his combinations, anything. The whole match was like a farce, really. It ended up in a draw. But Muhammad Ali actually suffered from what's called some DVTs, deep vein thrombosis, and had to be treated for that. And he could have very well lost his life if that wasn't picked up. I mean, his legs were swollen and bleeding by the 7th round, and it was really a mess. So that's another thing that I don't know how these Thai boxers do it, that constantly getting whacked in the back of the thigh and the sides of the thigh. So that's another risk factor. So if you're going to go into the boxing ring, make sure you're not going up against a wrestler who knows how to kick. And also a person who is prone to blood clots, somebody who has what's called a coagulopathy or a blood clotting disease. If you take a female who's on birth control and smokes at the same time, she has significantly increased her chances of developing blood clots. So those are some things you should be asking in the history. What medications are you taking? If you're asking about medications, make sure you're asking about birth control. If you're asking about history, make sure you're asking about cigarettes and other habits as well, because that could significantly make a difference in this person being RMA'd or getting the right care that they need. Dan, anything you want to add, or are you just hanging out?
I just talking to students one at a time to make sure that they're up to date on everything they need to be.
Okay. We good?
Everything's good.
Okay. So definitely understand a little bit about a pulmonary embolism. This is a thing you've got to think about when you can't think about anything else. Because these patients don't present like textbook. Anybody remember this actor? Anybody old enough? Probably not. He was very popular in the 70s, and then back then in the early 90s. His name was John Ritter. He was Jessica Rabbit. What? Okay, you got me on that one, but okay. His name was John Ritter. He was popular in the 70s on a sitcom called Three's Company, and then in the mid 90s, he was called 10 Rules for Dating My Daughter. Basically, No reason to ever really hate the guy, but in his early 50s, just dropped dead. And what happened was that he just dropped dead suddenly because he suffered from something called an aneurysm in his chest. An aneurysm is a weakening of an arterial wall to the point where it can burst. Kind of like having a bubble in the sidewall of your tire. That once that's done, that tire's shot. You can't fix it. You can't. Well, an aneurysm can be fixed, but it's got to be detected first. Most often, aneurysms are found incidentally or coincidentally when something else is being looked for. A person's getting a chest X-ray because they think they have a pneumonia, and all of a sudden they see this wide space on the chest X-ray. It's like, oh, you been getting back pains lately? And I'm like, oh, come to think of it, yeah. But I just thought because I didn't go to the chiropractor. The same risk factors for coronary artery disease are pretty significant for aneurysm, with uncontrolled hypertension being one of them. And most often, aneurysms, they can be found in the belly, in which case when you palpate the abdomen, you feel a pulsating sensation that shouldn't be there. But a thoracic or a chest aneurysm quite often presents as upper back pain without any trauma. When I have an older patient with lower back pain, I usually chalk that up as to mechanical in nature. But anything in the upper back, you have to really, really be concerned about. Don't blow it off as just a muscle pull, because especially if they're complaining right between the shoulder blades, a tearing sensation, please associate that term tearing sensation with a thoracic aneurysm. And don't be so quick to let them RMA. Another interesting finding, I don't think it's in your textbook, if you suspect that this person is having a thoracic aneurysm, take the blood pressure in both arms. If there's a significant difference from one arm to the other, by like 20 points or so, that's another pretty significant worry that this person may be having a thoracic aneurysm. Beg, borrow, steal, do whatever you can. Use your charm, whatever you can, your professionalism, to get them to go to the ER. You'll thank yourself later on. So we talked a little bit about the mechanical issues that can go along with the heart. There's also electrical issues that can be problematic in the heart as well. I don't know if we talked about during pathophysiology how theoretically I could just kind of plunge my hand through your chest and rip out your heart like a cheesy 80s horror movie, and the heart will still beat and beat and beat and beat. Well, I'm being a little dramatic there, but the reason the heart can theoretically do that is because it has a property that to generate its own electrical impulse. That's a property called automaticity. And the heart's the only muscle that has that ability. If I want to flex my big skeletal muscles, which I don't have, it would still take an impulse from my brain, down my spinal cord, to a nerve to do that. If I want to propel food through my digestive system and toss it out in the toilet bowl later on, it still takes a nervous impulse from my brain down the spinal cord to tell those smooth muscles in the intestine to do that. However, the heart can theoretically be disconnected from the nervous system, and as long as it's perfused, as long as it's maintained, it will generate its own electrical impulse. And we'll talk a little bit about how that works in a few moments. So let's get a little bit more specific into the mechanical issues that can occur with the heart. So we talked about an acute coronary syndrome being somewhat of a catch-all phrase for anybody that's having this kind of chest pain that also has risk factors for heart disease. Well, one issue that can occur and is more common than others is something called angina pectoris. We kind of already talked about that a little bit. And this is a very classic presentation in this painting by, what's his name, Netter, Michael Netter. There's all sorts of medical illustrations. What we mentioned before, that atherosclerosis is a process that occurs over time. It's a gradual narrowing of the coronary arteries to the point where blood flow is compromised. Now, a little bit of atherosclerosis is tolerated. Probably a lot of us have it, and a lot of us are developing it early in life. Heart disease has been shown in school-age children in this country. It's not a good thing. We talked about all the risk factors. But as that fatty buildup builds up and builds up, builds up, and then ultimately blocks off about 70%, give or take, of that artery, the individual may be fine at rest, but during times of stress, like this gentleman walking through the snow, walking up the stairs, carrying a heavy briefcase, he's a little bit older, probably just ate a big meal, so his digestive system is taxing the cardiovascular system as well. He's going to start feeling this pain because his heart is beating harder and harder, and it's demanding more oxygen, but there's a decreased ability to deliver oxygen to this heart. So is this person having a myocardial infarction? Not necessarily, because the pain of angina pectoris is usually reversible in the field. Get the guy in the ambulance, sit him down, let him rest, maybe give him a little oxygen if he's having shortness of breath. He may feel some relief of that pain. If he has pre-prescribed nitroglycerin with him, and you appropriately assist him with that nitroglycerin, he may even have more significant relief of that pain. So you sat him in the ambulance, you rested, his pain went from an 8 out of 10 to a 4 out of 10. That's probably good. That probably means he doesn't need to go to the hospital, right? Wrong. Okay. Because we still don't know beyond a shadow of a doubt, unless you have angiogram or an EKG, that this person is not having a myocardial infarction. You throw a 12 lead on him, okay, 12 lead may not show that he needs a CAT center, but he probably still needs to go to the emergency room. Just because the EKG is not showing anything doesn't necessarily mean he's not having an infarction, it just means it's not showing up. So always have a high index of suspicion. Just a side note, and for testing purposes, this isn't really something, but you very rarely see people prescribed nitroglycerin anymore. It's out there, but you don't see it as much as the textbooks would make you think there is, because most of the times people that have this condition corrected preemptively by having the cardiac catheterization procedure and having it done before permanent damage occurs. So before that, 30, 40 years ago, when we didn't really have that procedure widely available, people were given prescription for nitroglycerin for over 200 years. There's still quite a bit of an indication for that drug, but you just don't see it as often as you do today. What would that do to the surgery? Anthony, what do you mean? What would it do to the surgery? I want to answer your question. I just don't understand it. So and I think I have a video in your folder that demonstrates the process. So what they do is they go in through an artery with a fiber optic catheter, and they thread it actually through the femoral, through the groin, through the body, and they work it all the way to that artery. They look at it under basically an X-ray, and that catheter, once it finds its way through, it inflates a balloon. That balloon squashes the plaque to the sides of the wall and opens up that artery. And then at the same time, they put in like a little metal coil to keep the artery open. It's called a cardiac catheterization with stent. See, and that's become much, much more available and popular these days more than it was 30, 40 years ago, making the need for nitroglycerin a lot less indicated these days. Did I answer your question? I hope so. Yeah, look in your folder, and if I didn't put the video on it, I will after tonight. So now with angina pectoris, again, the common thread being that there is no damage to the heart, luckily. Ultimately, if the situation is not corrected, though, this person is at a high risk for having an acute myocardial infarction. Acute meaning sudden, prefix myo pertaining to muscle, cardial, heart. Infarction means death of. So what's the difference between angina and MI? Is that with the myocardial infarction, maybe you don't have that 70% blockage, but that artery has been compromised, it's damaged, and now a blood clot has formed, and now that blood vessel has been completely blocked off. It's usually a very sudden event. Some little, because that plaque has weakened the wall of the artery. Now, at some point, a little rip occurs, a little damage, blood clot forms, blood clot grows, blood clot locks off the artery. This is a true heart attack. This person will have the symptoms and signs of a heart attack, which will generally not be relieved with nitroglycerin, even if they have prescribed nitroglycerin, because the artery does nothing to open up. It's sealed. It may give them a little bit of relief, but it's not going to get much. And you can see that anything distal to that blockage is going to be compromised. And if that artery is not reperfused or reestablished within 6 to 12 hours, the part of the heart will die. And they may live in their life, rest of their life, with a condition called congestive heart failure. Congestive heart failure is not the same as cardiac arrest. All right? 60 on a test is still better than 0 on a test. Heart failure means the heart is just not getting the job done adequately. Now, there's a number of different reasons why the heart doesn't pump adequately, most common of which is because it's just getting worn out. Probably one of the most common causes of congestive heart failure is uncontrolled hypertension. Think about the heart is constantly beating against elevated pressure and elevated pressure, it's going to get worn out. If you constantly drive your car in low gear, you're going to wear out the engine and the transmission. So as the heart starts getting weaker and weaker, it has to work harder or do more to get the job done. So it's got to beat faster to compensate, to put out cardiac output, but ultimately it's going to have a hard time catching up. And so you're going to see these signs and symptoms of a heart that's just not pumping efficiently. It's not a heart attack. It may be a result of a heart attack, but it's just getting weaker and weaker. It may be tachycardic, because the heart may have to beat faster to compensate for the decreased stroke volume. There may be dyspnea, because the heart's having a hard time getting oxygen around the body. If it's really late sign, there's going to be cyanosis, because the heart's having a hard time getting oxygen from the lungs. It could be normal or elevated blood pressure, because remember, the heart's not going to pump efficiently. Other mechanisms are going to kick in to try to constrict blood vessels and increase cardiac output. Diaphoresis and an acute attack, but pulmonary edema is one of the biggest problems, because if the left side of the heart cannot pump out what's coming to it, blood is going to back up into the lungs, the capillaries are going to get engorged and swollen, and fluid is going to be squeezed out from the capillaries into the alveoli. And then oxygen is going to have a difficult time transporting. You're going to have a problem with that diffusion. Remember diffusion? If it's the right side of the heart that's in trouble, you're going to have peripheral edema. Where does the right side of the heart receive its blood from? The right side of the heart receives its blood from the rest of the body. So if the right side of the heart cannot adequately pump out what's coming in, fluid's going to back up. You're going to see pronounced jugular venous distension. You're going to see bilateral pedal edema. Now, the most common cause of right heart failure is left heart failure. The most common cause of left heart failure is uncontrolled high blood pressure. Previous history of myocardial infarction is another big cause of heart failure as well. There are a lot of other causes too, but these are really the most two important ones to talk about. Generally, you won't get a call for sudden congestive heart failure. Most of the times, you're going to get the call due to pulmonary edema secondary to congestive heart failure. Maybe they've been compensating and compensating and compensating, and all of a sudden something just, maybe they had, take out Chinese the night before, and then with the high sodium content, blood pressure spiked through the roof, and now they're spilling over. Or maybe they're having a little bit of mild myocardial infarction that doesn't show up on a 12. They're not even feeling any chest pain, so you wouldn't even know that they're having a heart attack. Yet their heart is failing, the blood is backing up. They probably won't call you for this as much as they will the acute pulmonary edema. Do we have any questions so far? Okay, guys, let's take a 10-minute break, and then the rest of the next segment should actually go through pretty quickly because a lot of it's review and a lot of it's pictures. We'll be talking about cardiac arrest. We'll start. I got 7:45 on my end. Let's start up at 7:55, and then we'll breeze through. All right, so starting up again, talking about cardiac arrest, which you've already had a little bit of because you've all been through the CPR part of this course. But let's look at what we're doing or what we're trying to accomplish when we're responding to someone in cardiac arrest. Now, remember, cardiac arrest is not the same as heart attack. Heart attack means there's death of a piece of a heart muscle. Cardiac arrest means the heart has stopped. Although when we say the heart has stopped, it's really not 100% true. It stopped beating effectively, but there is still some activity going on that if we can intervene fast enough, we can get that activity resuming normally again. But the chances are against us. So to understand how cardiac arrest works, you got to understand a little bit about the electrical system of the heart. Talked about the heart having this mechanical component. First, the atria contract, and the ventricles, the atria and the ventricles. But what drives that coordinated synchronous movement is the electrical system. And we talked about how if you take the heart out, you have a question? Raymond, you had a question? I thought there was a question. Okay. So what allows the heart to drive its own beat? It's a part of the electrical system. It all starts right up here in the corner of the right atrium. This little part of the heart called the sinoatrial node, or what's referred to as the pacemaker of the heart, the SA node. SA node fires basically an electrical charge, electrical impulse, so to speak. And that electrical impulse is carried through these other, for lack of a better word, wires or conduction pathways through the atrium. And it results in a process called depolarization. This electrical activity called depolarization is what tells those heart muscles to contract in the atria. And you can see that representation here on an EKG with that first little bump called the P wave. That P wave is representing that wave of electricity that's going through the atria as the atria are depolarizing. Now, if you look at an EKG, this tells you nothing about the heart's contracting. It's only showing you electrical activity. And then you notice there's a little pause right here. And what's happening is as that electrical activity circulates through the atria and allows the atria to contract, that activity is paused right here for a split second in the area between the atria and the ventricles called the AV node, or atrioventricular node, or the AV junction sometimes it's called. And that AV junction pauses that impulse just slightly enough to allow the atria to contract and fill the ventricles without having the atria and ventricles contract at the same time. Then after that pause, that electrical activity is carried down the center wall of the heart between the two ventricles, called the bundle branches, and then up these fibers called the Purkinje fibers, and then causes the ventricles to depolarize and then contract. And that activity of depolarization in the ventricles is represented on this EKG, where you have what's called a QRS complex, this nice tight spike that you would see on the EKG. And then even though you don't see it here, then you would see another bump here called a T wave, which demonstrates the heart resetting itself. So you see that if you ever looked at an EKG tracing, you can YouTube a video of it, or you'll see beep, beep, beep. Normally it's very steady, very regular, and in most healthy adults, usually between 60 to 100 beats per minute, give or take. So what's going on in cardiac arrest? Well, a couple of things happen actually. Actually, I should have reversed this. For one thing, switching slides here, we talked about what happens in myocardial infarction. A piece of that heart is not getting oxygen. It's getting irritable. It's getting messed up. It's firing in distress. We talked about the sinoatrial node, the SA node, being the normal pacemaker of the heart. This part of the heart is specially designed to lead the rest of the heart. Okay, the heart will beat as fast as the fastest beating cell. So let me describe that another way. As I said before, the heart can generate its own impulse. Even at the cellular level, if I was to take the heart out of the chest, dissect it cell by cell, put these heart cells in a petri dish, keep them alive, keep them nourished, get rid of their waste products, they would all beat independently on their own at different rates, different rhythms. Put them close enough together, they'll start joining each other, forming junctions, and they'll start beating together, almost like a chorus, hopefully a coordinated chorus. And whichever cell beats the fastest will drive the rest of those cells. And so that's what happens with the heart. The cells in the SA node are inherently designed to beat the fastest at 60 to 100, sometimes even higher beats per minute. The rest of the cells of the heart take over. Now, if the SA node fails, the heart has backup pacemakers. The AV node that we talked about before can take over as backup pacemaker if the SA node fails, but its intrinsic rate is about 40 to 60 beats per minute. And then if that fails, the ventricles themselves can take over as pacemaker, but at a much slower rate, 20 to 40 beats per minute. Not really adequate to sustain life, but hopefully to keep that person going until they can get medical intervention. But like I said before, any cell in the heart has the potential to take over as pacemaker as long as it's beating faster than all the rest of the cells of the heart. So now, where do most myocardial infarctions occur? They usually occur in the ventricles. So if you have one part of that ventricle, even one cell that's not getting enough oxygen, it's going to start breaking down, it's going to get irritated, irritable, and it's going to start firing away as fast as it can. 100, 120, 160, 200 times a minute. And it'll kind of a last-ditch effort to save itself, like it's firing a flare. It's going to go. And you can see that represented on the EKG by these wide yet regular complexes that don't have the characteristic P wave or QRS complex. Why are these wide, wider than the normal? Because instead of going through those nice paved tracks and the wires in the heart, that electrical conduction was burrowing through the heart muscle, like trudging through an unshoveled, snowy street. Now, if that rate is in the low end of 140 to 160, may be able to generate a pulse. Person will be feeling it, they'll be feeling palpitations, they'll be feeling dizzy, they may show signs of shock. When you start getting really fast, 200, 240, 280, 300 times a minute, that heart is beating way too fast to allow any blood to fill up the chambers. And if no blood goes in, then no blood goes out. If no blood goes out, no blood gets to the brain. What happens when no blood gets to the brain? Person passes out. They become unconscious. Because that heart's beating so fast and it's not pumping out any blood, are you going to feel a pulse? No, you're not. So that, by definition, is cardiac arrest. There's still some activity going on in that heart, though. Its game's not over yet, as long as we can intervene fast enough. However, a couple of minutes goes by, and what happens? Now, this part of the heart gets irritated. This part of the heart gets irritated. This part of the heart gets irritated. This part takes over as pacemaker. This part takes over as pacemaker. This part takes. Every other cell in the heart is trying to override itself to take over as pacemaker. So instead of that nice regular rhythm, or even that too fast regular rhythm, you've got this chaotic, sporadic type activity referred to as ventricular fibrillation. What we had earlier was ventricular tachycardia. This is ventricular fibrillation. And ultimately, if these situations are not corrected, you're going to have the most stable cardiac rhythm available, which is called asystole. Beep. For all intensive purposes, I mean, some paramedics would argue otherwise, but for all intents and purposes, it's synonymous with death. I mean, sometimes patient asystole can be brought back, but these are the exceptions, very few and far between. Because when you have flatline or asystole, there is no electrical activity in the heart whatsoever, at least none detectable. That's why the American Heart Association has really emphasized this and re-emphasized and readjusted its early cardiac chain of survival, early access, early recognition of cardiac arrest, and as far as early recognition of cardiac arrest, early recognition of who is likely to go into cardiac arrest, people with cardiac risk factors, people who are in danger of going into cardiac arrest. Early CPR. Okay, what's the purpose? Now let's be very realistic. CPR in and of itself will rarely bring somebody back from cardiac arrest, unless it's considered hypoxic arrest from a drowning or smoke inhalation, where the heart was already in good shape to begin with. But CPR in itself very rarely brings somebody back from cardiac arrest. What's CPR meant to do? CPR, the actual compressing of the chest and sometimes bringing oxygen into the lungs, is meant to buy this person a few more minutes. Give this person some extra brain cell life until definitive treatment arrives. Now, when the heart stops beating, how long does it take for irreversible brain damage to occur? Your textbook answer would be 4 to 6 minutes. CPR is meant to try to buy that person an extra few minutes, keeping those brain cells alive. It's really not about the heart. It's about the brain. Keeping the brain cells alive, staving off brain death until we can get that definitive treatment. What is that definitive treatment? Defibrillation. If that heart is in fibrillation, we want to defibrillate it. What do we mean by defibrillating the heart or using an automatic external defibrillator? Taking a jolt of electricity, overriding that crazy chaotic activity, and shocking the heart, knocking it out of whack, and letting it try to reset itself. Sometimes it works, sometimes it doesn't. But the sooner you get that AED to that individual, the better chances that it will work. Because once a person goes into cardiac arrest, every minute that goes by that they're without defibrillation, their chances of survival decreases by about 8 to 10%, give or take. And then the other links in the chain are rapid transport to the appropriate facility. And even this day and age, sometimes it's not necessarily the nearest 911 hospital anymore. Sometimes even post-cardiac arrest, it's a matter of transporting him to a cardiac catheterization center. That's all regional and protocol dependent, not something that we're going to worry about right now in classroom. And then getting the right post-resuscitative care. That's a little bit beyond the scope of what we do here at the BLS level. That involves medications, catheterizations, sometimes cooling therapy, and then, of course, recovery therapy from that point on. So your job at the EMT level, though, is after recognizing cardiac arrest, doing the best, most effective CPR you can do. Making sure your hands are in the correct position, compressing the chest at least 100 to 120 times per minute. No more than 1 second for each ventilation. Not overventilating the lungs, not hyperventilating the lungs. Minimizing interruptions of CPR in no more than 10 seconds between cycles. That's not easy to do. Sometimes it's impossible to do. If you have to carry that patient down 4 flights of stairs, you're going to wind up interrupting CPR. It's inevitable. You know, maybe you do a round of CPR, 2 minutes at each landing package, get ready to go down a flight and do another cycle. But the less you interrupt CPR, the better chances of survival. So high performance CPR is the key to increasing cardiac output. The best, most effective CPR only restores about 30% of normal cardiac output. So right then and there, even as you're doing the most perfect CPR, you're still behind the 8 ball. You're still not in good shape, unfortunately. So CPR by itself is not enough. And I said, as sooner the defibrillator arrives, the more likely the patient will survive cardiac arrest. So you get flagged down for somebody, they're pulseless, they're unresponsive, you go on the scene, you have your defibrillator, you have your partner, you have your BVM. What's the first thing you want to do? Well, assess your patient, start CPR, but do not delay defibrillating your patient. Let me give you another scenario. You're working with a patient who weighs, you're working with a partner who weighs 300 pounds. Your partner, I'm sorry, I'm mixing my words up here. Your patient is up 2 flights of stairs. You get the defibrillator, your partner gets the oxygen tank and the BVM. You run up the stairs, your partner falls through the stairs, you're in front of a patient, the patient's in cardiac arrest, you're by yourself, your partner has to get himself out from under the stairs. What do you do first? Do you do CPR or do you defibrillate the patient? Confirmed cardiac arrest. No trauma involved. Nobody wants to take a stab at that? The accepted protocol right now is do the defibrillation. Remember, every minute that goes by, less and less electrical activity occurs. Remember we talked about CPR is a means to an end. It is not the end. Defibrillation is the end. So the longer you delay defibrillating that patient, the less chances they have of survival. I mean, there is some research suggesting maybe that a minute or two of CPR is appropriate, but in general, no. We want to put the defibrillator, the AED on immediately. Obviously, if you have a partner or two that can start CPR while you're setting up the defibrillator, that's ideal. But under no circumstances should defibrillation be delayed if it can be helped. And you do know that this is a testable skill using the AED. At the end of the course, you're going to be tested on 6 skills. You have to pass all 6. Anybody that fails the defibrillation station should be beaten senselessly in the parking lot because the machine tells you what to do. As long as you know how to push a button, it is so easy. I mean, this is not the days of the 1980s when we first got these semi-automatic defibrillators and we had to interpret the rhythms and we had to make a call whether we wanted to shock them or not. These things are, I mean, they're all pretty much based on the same principle. Turn the power on, put on the pads, plug in the machine, push the button, and before you push the button, you say clear, and then start CPR. Most of these machines have instructions, but most of us men, we don't read instructions, right? So, but if you're married, you know how to do what you're told. So most of them tell you what to do. They have voice prompts. So, I mean, there's just no reason this is a problem. They actually did a study, I have it somewhere, comparing 6th graders to seasoned paramedics and found that 6th graders could use most automatic defibrillators just as effectively as seasoned paramedics. Probably better. Paramedics feed into things too much. So it's sometimes appropriate for you to meet up or rendezvous with paramedics en route to the hospital to tell the God's honest truth, that in the city, in the 5 boroughs, that's probably not the most efficient thing to do, because you're really never more than 10 minutes away from any hospital anyway. But just understand that if there's extended transport time, it is an appropriate intervention to meet up with the paramedics en route to the hospital. But working a cardiac arrest really involves a team approach. It really involves checking egos at the door and assigning a team leader, like a conductor, somebody to call the shots, somebody to make sure that oxygenation is adequate, that we're getting good chest rise with the BVM, that we're not overventilating or hyperventilating. 12 lead EKG is more, I'm not sure if it's really indicated, at least in New York City, in a cardiac arrest situation. Post-cardiac arrest, if you wind up getting the pulse back, it may be appropriate. Finding and managing treatable causes for the arrest, that's more of the job of the ALS, but you still want to be a thinking EMT. Determining appropriate destination for the patient. Hypothermia is not really indicated. It was indicated at the ALS level. There was a thought that by dropping the body temperature, by infusing cold fluids, we might have better outcome. That really hasn't been proven, at least as far as I know, last reading, to be very effective. It's not even an issue in the BLS level, so I wouldn't worry about that too much. It's more so of the best thing is like really having a team approach and doing everything coordinated. Your biggest job is obviously early CPR, early effective CPR, and rapid defibrillation. Those are the two major things. And again, you're not going to be doing CPR in a big open classroom with all the floor space available. No, you're most likely going to be working up your cardiac arrest with your patient wedged between the toilet bowl and the bathtub. He probably crapped himself. He probably threw up. He was probably an old guy that was straining to go to the bathroom, had what's called a vagal response, and then passed out. You'd be surprised how often that actually happens. Says here, there's usually enough oxygen in the bloodstream to postpone ventilation for the first several minutes while chest compressions are performed. At your level, so there's a lot of controversy on whether giving 2 breaths after 30 compressions is all in all that effective. At the protocol level, it's still appropriate to do 30 and 2, 30 and 2. But there's a big push for public access CPR that if people don't want to do mouth-to-mouth or rescue breathing, then just do compressions. Let's say if you're responding on your own time, you're not on the ambulance, and you see somebody go into cardiac arrest and you want to help, but obviously you don't have a BVM with you everywhere you go, and if you carry a pocket mask with you everywhere you go, you might be a little weird, but that's your thing. But if you don't and you still want to help, it's completely appropriate at the bystander level to do just compressions. There's usually, like the slide says, oxygen in the blood for a few minutes, but if the oxygen doesn't move, if it doesn't get to the brain, it doesn't do any good. So that's why it's okay to just do compressions at the bystander level. At the EMT level, the professional level, you should still be doing 30 and 2, or cycles, 30 to 2, or 15 to 2 if it's 2 rescuer, or 15 to 2 if it's child. Appropriate. Okay, so perform 1 rescuer, 2 rescuer CPR, take standard precautions. Always remember to switch compressors after every 2 minutes. No matter how strong, not how tough, or how macho you think you are, studies have shown that after about 2 minutes of continuous compressions, effectiveness diminishes, cardiac output diminishes, and then the chances of successful resuscitation diminishes. This is a textbook guideline. Use flow-restricted oxygen-powered ventilation device. I personally don't like those. I'd much rather prefer a BVM, and those are contraindicated in pediatrics. You also have to, beyond working up the cardiac arrest, at some point you have to think about how you're going to get your patient out of there. How are you going to extricate your patient? You got to have a plan. You got to think about obstructions, stairwells, the patient's weight, what kind of other resources you need. Do you need backup for? I mean, really, cardiac arrest should not be performed between just you and your partner. You're going to need help one way or the other. Preferably if you have ALS backup, but even if they just have BLS backup, come up with a plan to get that patient out of the apartment, the ambulance, and then to the hospital. If you can't, I mean, it's easier said than done to interview bystanders and family members. The more information you get, the better it's going to be at the hospital, but it's usually the extent of an interview. Honestly, it's going to be just, what happened? And I don't know, he was just complaining of chest pain and it became unresponsive. You know, how much of a history are you going to get with a hysterical family member? If you can, that'd be great, but if you can't, just do the best you can. It's a little bit academic. There's two types of automatic external defibrillators. There's the semi-automatic, which are the most common, which really it's a matter of just turning the machine on, hooking it up, and letting the machine read the electrical rhythm of the heart, and it will tell you whether to press the button or not. And fully automatic, where you just put it on and it does everything for you. It really depends on what you carry on your agency. Either way, it is your responsibility to be familiar with what type of equipment you have. You know, get a supervisor or senior person to show you the equipment, at least how to familiarize yourself with it. Don't worry too much about monophasic versus biphasic defibrillators. It just talks about how the energy is delivered. Most of the old defibrillators were monophasic, and in other words, it was a matter of how the energy was delivered, just in one direction from one lead to the other. Biphasic, the energy, the electricity. I don't know. Is it your phone? Biphasic just means that you're getting shocked from both ends, basically, and it's thought that biphasic might be a little more effective in resuscitating the patients, but neither one has really been shown, as far as I know, to be effective. But most defibrillators that are made these days are biphasic anyway, so that's really not even an issue. So yeah, what does it say here? Defibrillators work by giving the heart a controlled electrical force, forcing the heart muscles to contract at once and then hopefully jolting it back into the rhythm. It's not really jump starting the heart, it's really stopping the heart and giving the heart a chance to reset itself. And so this is in your textbook. I know it's kind of hard to see on that slide, but you also want to look at your New York State protocol as well. And then when you're out there, go over regional protocols. Because regional protocols, like New York City, has something a little different than standard AHA protocols. But this is a state class, so not city class. So in general, when you're working up a cardiac arrest, the defibrillator on the scene, what's the maximum amount of times you want to shock that patient before initiating transport? The answer is 3. So you get on the scene, you assess that patient, determine the patient's in cardiac arrest, have somebody start CPR immediately. If one person doing CPR, 30 compressions to 2 breaths with a pocket mask. If you have more than one rescuer, 30 compressions, 2 breaths with the PVM while you're setting up the AED. Make sure you take that shirt off, take whatever undergarments are off, put the pads on the bare chest, crank up the defibrillator, let it analyze. If it says shock indicated, make sure I'm clear, you're clear, everybody clear, stop CPR. Boom, shock. What do you do immediately after that shock is delivered? CPR. Do not waste time checking a pulse. Do not waste time looking around. Go right back into CPR. Don't say, are you okay? Are you okay? Even if that first shock or second shock or third shock works and gets the heart started again, it's not likely going to start for a good 30 to 45 seconds, at which point, if you waste time trying to check a pulse, that's just time ticking away that those brain cells are not getting any oxygen. So you give that shock, you immediately start CPR for 2 minutes. All else being said, after the 2 minutes goes by, and the machine will tell you when the 2 minutes have gone by, it's time to do that. You stop CPR, analyze, Let the machine charge. I'm clear, you're clear, everybody clear. Yell out clear, shock. Second time, right back to CPR. 2 minutes, same thing. Third time around, shock. Sorry, clear, shock, CPR. After the third shock, let's get ready to package. Package means get ready to transport. Put the patient on a scoop, longboard, whatever means you can to transport them out of the scene, onto the stretcher, and into the ambulance. Now, what happens if you deliver that shock and in the middle of CPR, you start hearing, ow, 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 stop, please, get off my chest, stop. That's an obvious sign of life, isn't it? And that sometimes may happen, in which case, awesome. Make sure you're oxygenating the patient well, make sure you're getting that blood pressure, make sure you're reassessing the patient. What happens if you put on the defibrillator, stop CPR, you let the defibrillator analyze, and the defibrillator says no shock indicated? One no shock indicated, continue CPR, get ready to package. Maximum of 3 shocks on the scene. Anytime it says no shock indicated, move out. So, what does the defibrillator actually work on? It works on 2 rhythms. Ventricular fibrillation, remember the little wavy, crazy activity, or ventricular tachycardia. Now remember, we said that ventricular tachycardia may or may not have a pulse. Usually doesn't, but if it's on the lower end, patient may have a pulse. Do you ever want to defibrillate somebody that has a pulse? No. So it's important that you assess your patient and determine that they are pulseless. Because if they are on the lower end of ventricular tachycardia, but they still have a pulse, it is a good chance that the AED might pick it up and might shock it, and then put that person from ventricular tachycardia right into a systole. And that would be a bad thing. So really, interrupt CPR only when absolutely necessary, a short period of time. Obviously, CPR must be paused for rhythm analysis and defibrillation. Don't do CPR while the AED is analyzing. It's too unstable a situation to do that. Okay, this is all basic BLS guidelines. If bystanders doing CPR, have them stop, verify pulselessness, apnea, absence of other signs of life for no longer than 10 seconds. Remember, pulse checks are not the easiest things in the world. Sometimes it's very difficult to determine if an unresponsive has a pulse, especially if they're breathing agonally. Every now and then they're going, I've seen seasoned veteran physicians waste time trying to check for a pulse when the monitor was basically asystole, thinking that they have a pulse, and what they're actually feeling is their own fingertips. No more than 10 seconds. If you do not absolutely, beyond the shadow of a doubt, know that there's a pulse within that 10 seconds, start CPR. Start CPR. If you start CPR and the patient stays, ow, stop, get off my chest, stop CPR. But don't waste any more time than you need to assess the pulse. Okay, so provide CPR, and this is just what we said before. One person begins CPR while the other person sets up. Remember, activate the AED, apply the pads, analyze, and shock. It's too simple. AED finds no shockable rhythm, it'll say no shock indicated. Now, maybe one of 2 things happens. Maybe there is some type of electrical coordinated activity that's occurring that's not generating a pulse, or at least a detectable pulse, or the person's flatline. You can't shock flat. Well, paramedics can shock flatline, but it's kind of no point to it because if there's no electricity in the heart to fix, there's nothing for the AED to fix. So, in which case, most of the machines out there don't display the rhythm, so it's kind of just academic. But either way, if it says no shock indicated, got to resume CPR immediately. But you do have to know the two shockable rhythms, which are ventricular fibrillation and ventricular tachycardia. So this is just another picture. And special considerations for AED use. Well, for one thing, make sure you yell out "clear" at the top of your lungs before you press that button. You do not want to be responsible for inappropriately shocking anybody else, especially your partner. Depending on who you work with, you may be tempted to shock your partner, but it's still not a good thing to do. What are some other indications? Well, don't shock somebody in a swimming pool. Take them out of the swimming pool and dry them up. Of course, if you're trained, don't do it if you don't know how to swim. But don't shock anybody in the middle of like a shower at a health club or anything like that. If they have a really, really hairy chest, male or female for that matter, those pads may not stick very well. Most of the AED kits come with little razor kits. It's not inconceivable that you may have to take time out to shave the areas where you put the pads on so they make good contact. Another trick that the AHA recommends that if your kit comes with 2 sets of pads, put the first pads on first and then rip them off, basically giving this person a waxing job, and then put the second pads on. You just better really make sure they're unresponsive before you do that. Anybody ever see the 40-year-old virgin? Most agencies won't like you to do that though, because those pads are pretty expensive. One set usually costs between $30 to $40, and it's not really an efficient means of using resources. If your patient has a defibrillator or an AICD is an automated internal cardiac defibrillator, you may see it like a little bulge sticking out of their chest wall. It looks like about half the size of half a deck of cards or the size of a stopwatch. Make sure you don't put the pads directly over that little item, just about an inch away. What else? If they're hypothermia is an issue. Most protocols say 1 shock and then go, because if they don't respond after 1 shock and their body temperature is really low, they're not going to respond until that body temperature is warm. So there's the old saying, they're not dead till they're warm and dead. Okay, so this is stuff we talked about. I think most of this is pretty redundant. Definitely go over your BLS guidelines, your numbers, your rates, your protocols. Anything else I want to cover here? I said that already. Yeah, very important is to always check out your equipment at the beginning of your shift. Make sure the AED is charged. Make sure it's got good batteries. Most AEDs have the ability to do a self-check at the beginning of the tour. If you're in the back of the moving vehicle and your patient goes back into cardiac arrest, have your partner pull over and stop before you reanalyze, because most AEDs cannot adequately analyze in a moving vehicle. Anything else? Let the operator of the AED complete the shock before. So if somebody is using an AED, like on the scene, like a first responder or somebody from the company, and they're in the middle of analyzing and delivering a shock, let them finish their shock and their cycle before you take over and put your equipment on. It says you may need to take the first AED to the hospital with the patient so data can be retrieved from the machine. Good luck with that. And the important thing is, if your patient does regain a pulse, remember to go back to proper BLS care. Avoid hyperventilation. It's 1 breath every 5 to 6 seconds, not every 3 to 4 seconds. The faster you ventilate, the more likely you are to cause gastric distension, the more likely a person is to throw up and aspirate. Another thing is, once the defibrillator is on, you keep it on, even during transport. There's no reason to take that defibrillator off. Even if the patient wakes up, leave the pads on. So here's the thing. let's say that you do cardiac arrest and you revive the patient after the third shock. He says, oh, wow, I'm feeling so much better. And great, okay, we package, we get him in the back of the ambulance. As soon as we get him in the ambulance, before your partner puts the ambulance in drive, it goes back into cardiac arrest. How many shocks do you give at this point? The answer is 3, because it's now a completely new cardiac arrest. You know, it used to be that back in the days of the city, the maximum number of shocks that an EMT would give on the scene would be 6. Now, when they had the EMRs, the fire department, come on the scene, they would give a maximum of 6 shocks as well. And then the ALS could come on and give a maximum of 8 shocks. So you can imagine like a really drawn out cardiac arrest that just stays in VFib. 6 shocks by the fire department, 6 shocks by the EMT, 8 shocks by the ALS, and more even. Imagine how that person's just gonna be a crispy critter by the end of that day. Luckily, it's usually not that case though. We're not gonna talk about therapeutic hypothermia. I think I covered all that. So, you know, witnessed cardiac arrest is your best. And I got to tell you something, really, despite what you see on TV and despite what you see in the ER, I'll tell you my experience for successful cardiac resuscitations. I've been in EMT for 30 years, paramedic for 25 of those years. The most successful cardiac arrests I've ever worked up in my whole career have all involved just basic early CPR and defibrillation. Very rarely have I had a successful resuscitation of a cardiac arrest where multiple drugs and IVs and all that other advanced stuff was involved. It's usually just goes back to the basics: early recognition, early application. I'm not gonna go into that. So one of the contraindications to defibrillating is cardiac arrest due to trauma. So a person's been shot multiple times, and it doesn't matter if you shot the heart or not. The heart has no blood to pump, it's not going to work. If they have massive tissue damage, it's not going to work. And here's a little bit of an exception to that rule, or at least something to think about. Let's say your patient was involved in a minor collision. You know, they crashed into a tree, there's not too much damage, but you find them behind the wheel and they're in cardiac arrest. You don't see any obvious major injury. Is it a traumatic arrest or is it a medical arrest? And I'm asking that question really rhetorically because you really just have to use your best judgment. Look at the scene, document the evidence. You know what? I would think that at that point, you're probably better off treating it as a medical arrest. And I mean, he's going to go to the nearest 911 anyway. It's not a matter of trauma center if they're cardiac arrest. So what do you got to lose at that point? Probably nothing. Obviously, if their head is partially off their shoulders, you're not going to defibrillate them. But if you're really, really caught between determining if it's cardiac, if medical or traumatic, probably go for the defibrillation. But that's just a suggestion, a personal suggestion. There's no protocol and guideline for that. I said for that, don't defibrillate a soaking wet patient. Got a patient that collapsed in the shower at the gym, take them out, dry them off. Do not defibrillate patients touching anything metallic that other people are touching. So if they're on a metal grate or beam or something like that. Oh yeah, nitroglycerin patch. Make sure you take off the nitroglycerin patch, or at least don't put the pad on the nitroglycerin patch before defibrillating. And make sure you yell clear at the top of your lungs. Make sure nobody's touching the patient. So look what she's doing. I mean, she's not looking at the machine, she's looking around the patient. The machine's not going anywhere. You need to scan around the patient to see what's going on. I talked about the implant device. I talked about, it's nothing, we'll talk about that later on. Okay. So your textbook may talk about mechanical CPR devices used in the field. They're handy. I think they definitely contribute to safety for the EMT point of view, because how can you safely do complete the back of an ambulance while the ambulance is in motion. You can't. So these new compression devices, and I think I have some videos on. I don't see. I didn't put the videos in your folder. Please remind me, and I will. You know, these automatic compression devices. Lucas is a popular one, but that's not an endorsement. They're good for maintaining compressions. None of them have been proven to improve patient outcome, though. So just to let you know that. Autopulse is another brand. Okay, when would you terminate or when would you stop doing CPR? Well, a couple of circumstances. Patient shows obvious signs of life. They start breathing again. They start their pulse. Remember, once you do your initial assessment, you don't really reassess the pulse unless there's a change in your patient's condition. You stop CPR once someone of equal training takes over. Another question. You're too exhausted to continue. Good luck with that. That won't work in class, sorry. You're presented with a DNR order, a valid DNR order, not just a verbal one. Obviously, use some common sense. If the scene becomes unsafe, then you're going to stop doing CPR. Once you start resuscitation, you must continue until arrest. So there's really no criteria for determining that the patient's non-viable. I mean, you could theoretically terminate CPR at the direction of your medical control physician, and that's usually not going to happen at the BLS level, though. That's usually just an ALS call. So, all right. So that's it. What I got for tonight. Do you have any questions? So just to recap, I would very much like for you guys to definitely know the anatomy and the basic anatomy and physiology of the cardiovascular system. Understand the term acute coronary syndrome and what that entails as far as angina, myocardial infarction, CHF. Know some of the ancillary problems such as thoracic aneurysms, pulmonary embolism. Know the risk factors for ACS. Know the typical signs and symptoms and presentations. Chest pain, nausea, radiation of pain, diaphoresis, impending sense of doom. Know the proper questions to ask when you're suspecting some type of cardiac compromise. Okay, Raymond. Well, we're recording this, so you'll be able to replay it tomorrow. Know the proper interventions. Know the contraindications to the interventions. Know what happens in cardiac arrest. Know the proper cardiac arrest protocol. Know the contraindications to defibrillating. Know the special circumstances regarding defibrillation. If nobody has any questions, I'll stay online for a couple of minutes and then wish you well. With that, then everybody have a good night.